The objective for today is to identify the need for national healthcare reform, compare and contrast healthcare reform proposals in the past, discuss the Affordable Care Act of 2010, explain the need for entitlement reform, and discuss various state proposals for healthcare reform. So in the national healthcare reform, there's three major problems: the quality of healthcare, the access to healthcare, and the current cost of healthcare. So for quality, in 1999, a research report was added called "To Err is Human." Reported medical errors kill between 46,000 and 98,000 Americans every year. Additionally, 1.2 million Americans experience an adverse event which extends their hospital stay or causes a disability, half of which of these events were reported as preventable. BMJ, formerly the British Journal of Medicine, reported 250,000 Americans die each year from medical errors as well. It's the third leading cause of death behind heart disease and cancer, and the federal government argues that the ACA is improving lives because since the implementation of the ACA, medical errors have dropped 17% approximately, and ACOs have saved approximately $417 million for Medicare spending. So the goal of the organization Healthy People 2020 is to improve the access to high quality services by the year 2020. Additionally, the access before the ACA, 17.2%, or roughly 55 million Americans, had no health care. Proponents for the ACA, they considered it a right and they wanted it. Some of the arguments against the ACA was that the arguments were that needy Americans were already covered by Medicaid, Medicare, and CHIPS. Now, they also argued that young people, which represented about roughly 17.2%, the majority, 17.2% of the uninsured, risks were very low, and so they did not need access to health care. So it seems that the ACA is working for the most part. By 2015, 10.2 million had coverage through insurance premiums. 12.3 million more had coverage because of the Medicare expansion, and 2.3 million young people were covered by their parents until age 26. So the cost of healthcare. So it's a big problem because government is spending too much on healthcare. Approximately $3 million was spent in $3 trillion spent in 2016. 35% of it was at the federal level, 6.3% was at the state and local level. Obama gave a speech which summarizes the points. We get a couple highlights here, and essentially the U.S. spends about 1.5 times more per person, but we aren't any healthier than other countries. Premiums are increasing faster than the wages of people, so healthcare is becoming more expensive, and people are not making enough money to cover those costs. We spend more on healthcare than all of the other government programs combined, so that includes like our military and our road innovations and all kinds of stuff. So some of the proposals to reduce costs, they got 10 of them here. So the idea is to replace fee-for-service with value-based contracting, increase the supply and utilization of PCPs, physicians, and physician extenders, focus on management of chronic diseases, pass tort reform, encourage use of physician-owned ambulatory surgery, imaging, and specialty hospitals, encourage formation of multi-specialty groups, practices, and integrated systems, reduce the administrative complexity, stop accepting excuses that providers cannot cover their costs under public programs and must shift to unreimbursed costs to the private sector, which, if you go back to my previous slide, highlights a problem that people aren't making enough money, and by shifting the cost to private people actually hurts them twice. They need to expect more from the customer, which would be us, me and you, to simply be healthier, to take preventative action, and to develop strategies that would work for the end-of-life decision-making. So some of the early healthcare reform. So in 1973, Congress passed legislation to facilitate HMOs. In 1984, Congress passed a Deficit Reduction Act, which limited reductions employers got for offering coverage shifted costs to the employees. So essentially the idea was to make them more cost conscious so that they could understand how much money it costs and they could pick their own insurance coverage and maximize what they wanted based on their risk, their needs, and their health. In 1989, the Omnibus Reconciliation Act of 1889, it ended Medicare charge-based reimbursements and initiated a competitive environment under prospective payments until 1992. So some of the unsuccessful legislative reforms were the single-payer proposal, the employer-based proposal, and the managed competition proposal. So in the single-payer proposal, one person, the government, generally would pay everything. Some of the good things about it was that it eliminated cost shifting to the private sector because the government would take control of all of it. However, it would shift the cost to the public sector, which generally isn't very good at controlling costs because there's not enough oversight, and implementing oversight would make it cost too much. The employer-based proposal, the argument was that employers, businesses could afford to completely pay the costs for their employees and pay for their health care. However, so some of the benefits of it is that it would reduce government spending because employers would take the burden of everything. However, the startups would suffer. A new business trying to grow would then have to take on a huge amount of responsibility, and it would kind of choke a little bit of capitalism out, which is one of the arguments. And employers would tend to dump high-risk employees. Now, we know that's illegal, but it would basically happen anyway. And so that was rejected as well. The managed competition proposal, it essentially combined the government regulation with the free market. Some of the good things about it was that it might lower the cost and improve access. It would also subsidize the sick with the healthy. Like healthy employees would pay a little bit more, or basically everything would balance out. Some of the bad things about it was that it discouraged incentives for healthy lifestyles, and it would limit physician choices. It would not give beneficiaries a lot of choice in the matter of who their doctor was. So in 1993, the Clintons, they had a proposal. It's called the Health Security Act of 1993. Essentially, it was a compromise between the single-payer plan and the market-based reforms. It was attacked out of a dislike of the idea of a big government monitoring that, and it was never voted on because nobody in the White House or Congress was ready for it, and they were more comfortable with the current incremental legislation that had been occurring up until that point. So we're going to start talking about federal reform. Some of the things that the federal government has done is the implementation of HIPAA. It helped get insurance for covered individuals who had like a job change, family illness. It just kind of helped cover them in those gaps. The implementation of medical savings accounts and the healthcare tax rule change, which allowed a self-employed person to increase their deduction for healthcare costs and insurance premiums by 30%, essentially paying for their own healthcare and getting the deduction from it. Some more federal reform. The Balance Act of 1997 gave more children access to healthcare. It also cut costs however, it did cut. So the idea was to cut $115 billion over 10 years. However, it ended up cutting more costs, which led to the Balanced Budget Refinement Act, which tried to fix that problem. Medicare, Medicaid, and CHIP reform was also implemented. Medicare Prescription Drug Improvement and Modernization Act, or the MMA, allowed for discounts on prescription drugs for Medicare recipients. Reform continued. We have the American Recovery and Reinvestment Act. It essentially provided $224 billion for education and healthcare for employees and people in the healthcare industry. The idea was if they were educated, they would cut costs over time. Additionally, there was the Patient Protection and Affordable Care Act, which expanded coverage to approximately 32 million people. It reduced the rate of increase in Medicare and Medicaid spending, improved the coordination and quality of patient care. It provided grants and loans to improve the workforce education and training on healthcare issues. Additionally, also allowed new reporting for tax exempt hospitals, kind of to keep them honest, and restrict expansion of physician-owned hospitals. So we have more government reform. In 2011, the Budget Control Act was implemented. It cut at least $1.2 trillion over 10 years. The idea was that if the committee could not identify cuts on their own, a Sequestration Act would be enforced, which is an automatic cut across the board. However, the board did not meet the requirements, and it was enforced. Additionally, the American Tax Relief Act was implemented. This was, as they knew they weren't going to meet the deadline, it was able to delay it by raising the tax on the wealthy. However, after delay, a across-the-board cut to Medicare was given by 2% for hospitals, which equates to roughly $10 billion over the next 10 years. So some of the state reform. Massachusetts was the first one to kind of start the forerunner in this, and they had a mandate for individuals to find health insurance or pay roughly $1,000 fine each year. Medicaid and CHIP expansion to provide health care insurance for families, making 150% of the poverty level. There was a mandate for employers with 11 or more employees with health insurance coverage. A state plan, Commonwealth choice, to provide health insurance coverage at group rates for those making more than 300% of the poverty level, and a waiver based on affordability standard for those making less than $114,000 who could not find health insurance coverage. So some of the free market reform is HMO participants reported better care during the last 6 months of terminal illness. The last 6 months of terminal illness consisted of about 21% of Medicare spending, and HMOs seemed to reduce the cost. Another option is direct contracting, which are contracts between employers and integrated delivery systems, and it would stimulate competition between different contracts to kind of in a free market way to lower the cost overall and help control costs. So the future of healthcare, we as administrators and people going into healthcare are faced with 3 brutal facts. The healthcare bubble is eventually going to burst. Neither ACOs nor first-generation clinical integration are producing the desired results. Physician autonomy and organized medical staff are becoming less relevant. So the healthcare bubble bursting. This issue is quite simply the American population is aging. As they age, it's going to cost more money to take care of them. The ACA seems like it's not going to be able to reduce the spending on healthcare. They weren't able to do it when it was first implemented, and the cost of it is only going to get worse, so it just magnifies that problem. At the state level, we are not going to be able to handle the rising costs from the elderly. And in order to reduce healthcare costs, the government will have to lean towards bundle payments and captive payments to reduce healthcare costs. Depending on where you're at in the program, you might be in the internship or preceptor stage, and you might see things like the BPCI program, which are introductory levels of solutions to maybe fix this problem that were highlighted in the networking event earlier this semester. So it's something that we should definitely pay attention to. So the lack of desired results. Essentially, they're trying to cut the budget and they're not getting what they want. So they're generating significant savings for Medicare fee-for-service patients is hard for integrated medical groups. They're just not saving money, it seems like. When groups receive shared saving payments, the payments are often insufficient to cover the increased costs. So they're trying their best, but it seems like they're not working, and it's not going to cover the cost of the actual service. And so it's going to be a long-term problem that they need to either get on board or change, because people are losing money trying to save money. So to reduce autonomy of physicians and relevance of organized medical staff. So hospitals need to work with the medical staff to modify the staff bylaws to require conformance to patient safety, satisfaction process, and quality metrics. Additionally, Hospitals need to develop a medical staff organization in which medical leaders have authority over cost, quality, and patient satisfaction decisions on physicians. Essentially, we need a medical overboard to watch the quality and cost of medicine and essentially cut costs where we need in order to make these programs work. So President Trump, he implemented a sort of a healthcare plan. So he repeals and replaces Obamacare with health savings accounts. He allowed people to purchase insurance across state lines, trying to create a dynamic market, kind of like this, free market healthcare across state lines. So it allowed us as citizens to look for our best healthcare out there. Maximize flexibility for states via block grants so that local leaders can design innovative Medicaid programs that will better serve their low-income citizens. It allows a little bit more autonomy for the states to take care of their essentially poor people. Also allows work with the states to establish high-risk pools to ensure access to coverage for individuals who have not maintained continuous coverage. So that's the end of the presentation and chapter 16. So it was a pleasure working with you guys this semester, and good luck on the final.